So I'm going to be talking about cardiac dysfunction and sepsis. And I have no commercial conflicts of interest. I'm not involved with industry or anything like that, but I do have some intellectual biases that are probably worth mentioning, in that I teach ultrasound. My academic career is largely based on ultrasound, so I do think it's important. But take that with a grain of salt if I'm saying how great ultrasound is. Okay. We'll talk about kind of an overview of sepsis, multi-organ dysfunction syndrome, and then I'll talk briefly about some of those challenges, about why we have challenges trying to define what is septic myocardial dysfunction. And then we'll go over some of the more common assessments. There are plenty of additional ways that we could define myocardial dysfunction, but we're going to go over some of the more common ones. So kind of as way of review, I thought we'd start with a nice cartoon showing the pathophysiology of septic shock. Now, part of the reason I went into echocardiography is that in high school, I liked physics and easy math a little bit more than I liked biology, which seemed a little hard to remember. So this is not my strong suit. We'll talk a little bit about this pathophysiology, but I think the key point here is that when you have an infection, it can lead to a pathogen that triggers a receptor on a cell surface somewhere. And that ends up leading to an inflammatory response. Now, some of those mediators that are listed in there can act as potentially a direct myocardial depressant. In fact, in the 80s, when they were trying to figure out what this mysterious myocardial depressant factor was that was causing all of these patients to have poor contractility, they proposed a lot of different potential molecules, including TNF-alpha, interleukin-1 beta, interleukin-6, as well as some of the less common immune mediators like P38 or the complement system or the nitric oxide dysregulation. I'm sure I'm probably, by relegating that, offending several basic scientists who focus on inflammation. But at any rate, there's this large immune response that occurs. And then what ends up happening is that, aside from other things, it will cause a change to the peripheral vascular bed, right? So a lot of these mediators will cause some microvascular thrombosis or vasodilation, capillary leak, edema, mitochondrial dysfunction, and that ends up causing problems to a lot of organs, including one of the organs, the heart, all right? And so that decreased perfusion, decreased venous return, that can affect cardiac output, but then it can also cause problems where you may have toxic response of the actual the cells in the heart. You could have swelling in vasodilation, tissue edema of the heart itself. But this leads to a big problem where you have decreased cardiac output, and your autonomic system tries to cover this by saying, let's crank up, the epinephrine or the adrenaline in our body. And while that will cause some increased contractility and increased tachycardia, sometimes that dysregulation can actually worsen cardiac function. The result of that can lead to tissue edema in a lot of different organs, but the one that we see most commonly is the lung, which is, I assume since most of us here are pulmonologists, God's organ, the only organ that really matters. And that edema causes hypoxemia, and that will cause pulmonary vasoconstriction, that increases right ventricular afterload, and that puts more work on the heart, as well as causing problems with more damage to the peripheral vascular bed. So you can see that sepsis ends up becoming this vicious cycle where the imbalance of one organ ends up leading to this complete system cascade failure. And tissue hypoperfusion ends up causing more cytokine release, which worsens the organs, and it just keeps going until you either get better or die. So what is septic myocardial dysfunction? We've got a couple of different echo images here, and I'm going to kind of show you all three of these could be considered septic myocardial dysfunction, or in some cases, septic cardiomyopathy. And those terms are sometimes used interchangeably and sometimes used differently depending on which person is speaking. But one challenge is that we probably are lumping together several distinct disease pathways into one common syndrome. So on the left, we see this septic heart that's got this profoundly decreased contractility, barely pumping at all. right? And you don't need to know echocardiography to recognize that that thing is not squeezing very well. In the middle, we have a septic heart that's got a low afterload state. It's hyperdynamic. You can see that it's contracting vigorously. And you might think that's normal or perhaps even great contractility, but I'll show you later on that there's some assessments that can show that this is actually impaired contractility. And then on the right, we have a septic heart with excess catecholamines causing the classic Takotsubo pattern, where you see apical ballooning, basal hypercontractility, and all of these fall under the rubric of septic myocardial dysfunction. And so this is one of the challenges here when we say, well, what is septic myocardial dysfunction? Is we're probably lumping several different things together. So how should we define them? Well, one possibility is to look at ventricular impairment. And we could say, well, there's systole and diastole. We could look at that. And that's classically what was done in the 1980s. That was how we first described septic cardiomyopathy. Another way of looking at it is to say, well, what about the function of the heart? Is this delivering appropriate oxygen, or is it delivering appropriate cardiac output? And a third option would be to look at, well, what's going on with the cells? Are the cells actually getting damaged? And one of the challenges with all three of these definitions is we still haven't really linked something to say one of these definitions clearly is associated with some sort of treatment target that we can act on and show a difference in outcome. We can identify some patients who are more likely to die. We can identify some patients who are perhaps different phenotypically to others, but we haven't really said this is a perfect definition to identify someone who we can treat with a targeted therapy. And one of the classic ones would be biomarkers, right? So troponin and BNP are probably our most common cardiac biomarkers that we test. And as I think anyone who's spent any time in the ICU can tell you, they're very commonly elevated in critically ill patients, regardless of whether or not they have what we would consider like cardiovascular disease. 88% of septic patients have some elevation in troponin. Now, we may not get too excited about a minimal elevation in troponin, but the point remains that the majority of patients that we're interested in have some elevation in troponin, which makes it a poor marker for trying to identify septic cardiomyopathy. Similarly, BNP is also frequently elevated. And one of the key points here, as you can see on this graphic, it doesn't really seem to differentiate between those with and without septic myocardial dysfunction by echo. It's elevated in patients who have renal disease. It's elevated in patients who have excess afterload, where you can have, for example, RV overload from ARDS, and that's causing strain on the heart. It doesn't seem like these are clinically useful, and I think we see this in practice. Very few people will use troponin or BNP purely to identify whether or not someone has got septic cardiomyopathy. Interestingly, there was a recent study that was published in the Blue Journal that was a large population study, very well done methodologically speaking, of over 14,000 patients who had sepsis and troponin measurement. And then they looked at peak troponin elevation. And they found that people had, with elevated peak troponin elevation, had a higher rate of cardiovascular events in the subsequent year. And that increased the higher their peak troponin was. So it's not entirely worthless for trying to identify whether or not someone has a worse outcome. Patients who do have an elevated troponin do worse. And that's whether you talk about post-discharge cardiovascular events here, or whether you're talking about atherosclerotic cardiovascular disease or heart failure. Interestingly, didn't seem to increase the risk for atrial fibrillation, presumably because atrial fibrillation in the septic shock population ends up being fairly common. And so it didn't necessarily increase your risk whether or not you had elevated troponin. This was really sophisticated analysis where they did multiple adjustments for both pre-sepsis factors like BMI, comorbidity, smoking, whether or not they were on a statin or an antihypertensive, as well as things during sepsis like what their Apache score was or SOFA score, and labs like CBC or chemistries, lactate, whether or not they were intubated or received vasopressors. Similarly, BNP and pro-BNP by themselves have historically thought to be pretty poor predictors of whether or not someone's got septic cardiomyopathy, but this was a systematic review of 36 studies looking at BNP in septic patients It was about 3,500 patients pooled when they took everyone together, and they found some association with BNP and pro-BNP and short-term mortality, meaning 28-day, 30-day in-hospital mortality. And they found the optimal cutoffs were about 620 for the BNP and about 4,000 for the pro-BNP. They had a lot more specificity than sensitivity. I think the BNP had a sensitivity of about 70% and specificity of 91%. You can see that on the ROC curves where it seems to favor specificity. They also found that if you measured early within the first 24 hours, you had better discrimination than those patients who had measured after 24 hours. So early BNP seemed to have a better correlation with mortality. Now, whether or not that means we've identified a target for treatment is yet to be seen, but at least we've identified there is a group of patients who are more susceptible to death with these elevations. Now, that's all great, but I'm here to talk mostly about echocardiography, which is what I'm excited about. And this is really how we define septic cardiomyopathy in practice for most patients. There are some challenges with echo, though. So one of the big challenges here is that the overwhelming majority of septic echo studies have been performed during late sepsis. So instead of being done within the first 6 hours or 12 hours, most of the published studies are looking at 24 to 72 hours after sepsis onset. And that leads to a couple of challenges with interpretation. One, the evolution of sepsis changes over that first couple of hours, and you can have big changes in cardiac function. And so what time you measure, you're identifying different people. And then the second is you're susceptible to immortal time bias, which means the sickest patients are probably going to die before you ever get a chance to study them within the 24 to 72 hour period. So unless you have a site that routinely performs echoes on all septic patients, most of these are going to be susceptible to selection bias unless you have something that is prospectively performed. Another issue here is that if you're using clinically obtained images, you have that same challenge with selection bias. And perhaps even more so is that loading conditions often are conflated with intrinsic myocardial function. By that I mean, if someone has really bad ARDS and they are on a ventilator with high pressures, that will stretch out the RV and affect RV contraction. And so that doesn't necessarily mean that the RV is poisoned or not functioning well. It may be responding normally to just excess work. And one of the challenges here is those things that affect loading conditions are very common. Fluid, vasopressors, and ventilation are extremely common in sepsis, as we all know, right? So it's a good expectation that maybe half to maybe 2/3 of your patients will have some sort of factor that will affect loading conditions. And to just give you an idea about what happens over time, this is actually one of the first echo studies that was looking at septic patients. And it was done using transesophageal echo. In France at the time, this was considered kind of like standard of care, was done without consent. They just said, sure, we'll throw a TEE in all of our intubated septic patients. And you can see here on the left, we have a group of patients who are normal ejection fraction or normal-ish ejection fraction and stayed that way for the first 3 days. And then they did a follow-up several days later. And then we see a group that starts off with a low ejection fraction. That's the middle, the B plot. And you can see in a large number of them, over the next 3 days, they start to improve. But there was also a group that started off normal and then either on the second or third day got worse. And so we can say, when we're trying to identify these, we're looking at a snapshot in time, and that doesn't always give us a whole picture of what's going on with the heart over the entire period of sepsis. All right, so how should we measure LV systolic function? And so the common idea is low ejection fraction. And as I had mentioned before, one of the problems with ejection fraction is it's highly dependent on loading conditions. So I'm going to show you this picture right here of someone who is, we would call it hyperdynamic and hypovolemic. Right? And this person is a septic shock person who's got low afterload, maybe low preload as well. They are contracting vigorously. Now, when the first septic myocardial literature was described in the 1980s, it was defined as low ejection fraction and probably a little bit of dilated LV. Interestingly, in that old literature, patients with worse ejection fraction actually did better. And that's probably in retrospect due to differences in filling pressures and afterload. So perhaps those patients with the worst ejection fraction were people who had adequate preload. And then these people here who looked more like this, who had an ejection fraction at the 75, 80%, actually had low preload. And their contractility wasn't the issue, but perhaps it was a problem with inadequate volume resuscitation. And the other challenge in this is our culture for volume resuscitation has changed dramatically over the past 20 years with the publication of early goal-directed therapy, and then now with the pendulum kind of swinging the other direction after the FEAST trial, and more recognition of the toxicity of fluid administration. But here we can see that ejection fraction, even though it's very high, doesn't necessarily mean good stroke volume. This heart, even though it's squeezing vigorously, isn't pumping a whole lot of blood out. One way we can perhaps identify this a little bit better is using a novel technology called deformation imaging, or strain. Now, strain is, simply speaking, if I were to take this green line, if I just trace the endocardial border here, and I just trace that, and then I stretch that line out into a straight line, how much shortening does that line have during contraction? All right, so that's one way to look at how much the ventricle is deforming. And we can actually look at that for all these different segments of the heart over the point of the cardiac cycle. Now, this is a piece of software that traces the little speckles and tracks them over the time of contraction. So the heart is contracting, and it's going up and down. But if we were to look at this through the whole heart, and we did this through different measurements like an apical 4-chamber, an apical 2-chamber, or a long axis view, we could actually plot every little segment, see how much it contracts. Now, you'll notice all these are negative numbers. And that's because strain is traditionally described as how much does something lengthen. And so if it shortens, this is basically the percent that that green line would shorten. So I want you to take a look again at that same echo. And I want you to take an appreciation here. We can see this thing's contracting pretty vigorously, but if you were to draw that green line over the heart, you could see that there's actually not a whole lot of contraction of the, in the apical posterior, the longitudinal dimension. And part of that is one of the myofibril directions here. Instead of being ringing out, it's also going up and down. And we're not seeing a whole lot of that. We're just seeing the heart moving in and out, left and right, moving in and out from side to side, but we're not seeing a whole lot of up and down movement. And so when you actually measure this person's strain, it's actually abnormal, despite having an excellent ejection fraction. And to kind of demonstrate how ejection fraction is too dependent on load, this is actually a interesting study that shows the patients who have sepsis and trauma with a normal ejection fraction. You can see here on the left, all the people who were above this line. If we were to take this group and look and measure and see what their strain is, we see a substantial number of the patients have abnormal strain. Now, again, you'll notice the higher number or the less negative number is worse. So a good strain would be somewhere around -20 or lower. And these patients right here have abnormal function. And these are all people who would have a normal ejection fraction. And the suspicion here is that some of these patients are patients who probably have insufficient preload. We've done a couple of small studies that have shown some, clinical correlates with clinically relevant markers, like, for example, delivery of oxygen or consumption of oxygen. And we found that strain seems to correlate with SCVO2. It seems to correlate with lactate and worsened renal failure in septic patients. But the reason we looked at this was because in cardiac patients, strain appeared to be the more subtle marker for myocardial dysfunction that was missed on traditional echo. And so now if you are looking for someone who's got ischemic heart disease, strain is really the more subtle or sensitive marker. And we thought, well, let's try looking at this in septic patients. And we weren't alone. There were a lot of other people who looked at this. And this is an excellent meta-analysis, fairly decent size, using that prior data that we had shown plus others. And it showed that strain appears to be associated with survival while ejection fraction was not. So you can see here on the top, strain seems to trend towards having a better correlation with survival, and ejection fraction essentially doesn't seem to have a good correlation. So moving on to diastolic function, this is a little bit less intuitive for a lot of people than contractility. I mean, you can look at a heart and see how well it contracts. It's a little bit harder to look at it and guess how it relaxes. So I'm going to kind of explain a little bit of the physiology here. The phases of diastole are, like everything, we have to just make it way more complicated than it's simple. It's not just relaxing, right? So there's this kind of almost snap back, like if you compress a spring too far, when you let go, it springs back. And so some of that is this kind of early rapid, almost suction effect as the heart springs back to its natural state, and you get a rapid filling here, and then you basically get a pause as things kind of equal out and the pressure between the left atrium and the left ventricle kind of equilibrating. We call that diastasis. And then the last little bit is the atrial kick. Now we could measure how much blood is flowing in to the left ventricle. We can actually measure the speed of blood as it flows in. And we use that using pulsed wave Doppler. And what that is off an apical 4-chamber view. We will take the probe and we will put this little marker right here at the leaflet tips, and we will measure the speed of blood as it's shooting towards the ventricle. All right, as long as everything's lined up, it's a fairly accurate measurement. And here's what it looks like. So here we have in centimeters per second or meters per second how fast the blood is rushing towards the left ventricle during early and atrial diastole. So this is early diastole, atrial kick. And you can see here, blood rushes fast, slows down, diastasis, atrial kick. All right? And we can see a lot of different cool assessments based off like the slope of this line or how quickly or what the ratio between these two are. But that doesn't give us the whole picture. The other thing that we can look at is how rapidly the heart expands. And we use tissue Doppler for that. It's also a form of pulse wave Doppler, but here we're putting the probe over the tissue of the mitral annulus, in this case, the medial mitral annulus. And we can do it off the lateral as well, but we do it right here off the medial. And we watch how quickly that heart expands, how quickly the annulus moves away from the ventricle. And that right there is our E prime and A prime. And these are in centimeters per second. S prime would be how quickly it's moving up towards the ventricle during contraction. Now, these two by themselves give us some picture, but the real beauty is when you put them together. And so when we look at diastolic dysfunction, I'm showing you this even though this is an outdated definition because the old definition kind of relied on pattern recognition. But what you can see here is we would have an E, or an early wave of velocity of blood rushing into the ventricle. And as the heart gets stiffer, it slows down, but then it starts to speed back up. And why is that? It's because the left atrium pressure starts to get higher and higher because it's the only solution for elevated LV pressures or elevated LV stiffness. But if we look at the E prime, which is how quickly the mitral annulus moves down, we see that that decreases and then basically stays decreased with a few exceptions here. Now, if we were to try to parse this out, well, we'd say whenever you have a flow of blood, well, there has to be a pressure gradient. And the faster the flow of blood, the greater the pressure gradient. So I can think of my velocity of blood as essentially the pressure gradient. And then if I look at the speed at which the ventricle is expanding, well, that's kind of like my change in volume. So I've got a delta pressure over delta volume when I look at this. And this is essentially giving me 1 over my compliance or elastance. And so the stiffer the heart, the worse or higher your E to E prime is going to be, the ratio of these two. So if you look at the ratio of these two, well, E goes down and then back up, and E prime goes down and stays down. The ratio of those stays the same. And I'll show you in a later slide how well that correlates with wedge pressure. Now, this definition was replaced by a way more complicated definition, and you do not need to know this, but the American Society of Echo put out a more complicated definition that tried to acknowledge the fact that not everybody fits well into those boxes. But a couple of things that are kind of limiting, and the reason I point them out is they rely on tricuspid jet regurgitation velocity and left atrial volume index. And the presumption here is that for your outpatient heart failure person that's going to have elevated PA pressures or elevated left atrial volume index, those are all probably downstream effects from having a stiff heart. In the critically ill patient, those may not apply. We have plenty of reasons for why our patients might have elevated PA pressures, including being on a vent or having pneumonia. And if you have someone who's acutely ill, the left atrial volume may not increase until several weeks to months. So I could take a normal person, fill them full of fluid, and the heart will be stiff or congested, but the left atrium may not expand enough to actually be considered pathologic. But when we look at that E to E prime ratio, it's essentially a way of taking the load-dependent part of mitral blood flow and the load-independent part of ventricular contraction or expansion. And as I said, it's the delta pressure over delta volume. And so the low E to E prime generally means a low wedge pressure or a low left atrial pressure. High E to E prime means a high wedge pressure. And there's a couple of caveats, but in general, it works pretty well. And this study has been demonstrated remarkably well in patients with heart failure and without, as well as with direct ventricular catheterization, as well as wedge pressures. But you can see here the E to E prime average correlated very well with the pulmonary capillary wedge pressure in patients. And you could basically say anyone who had an E to E prime of 15 or higher was probably elevated pulmonary capillary wedge pressure. And anyone who had an E to E prime of probably 9 or lower had a low pulmonary capillary wedge pressure. And you can extrapolate this out to these different groupings and say, well, based on normal impaired relaxation, pseudonormal or restrictive, I can kind of guess roughly what my left atrial pressure or pulmonary artery occlusion pressure would be. Now that we've kind of done that physiology, how useful is this? So diastolic dysfunction appears to be pretty well associated with mortality. This was one of the first studies looking at this, about 260 patients. And you can see here the purple and kind of tan line are people who had a low E prime wave. So that's people who had diastolic dysfunction of some sort. They didn't measure how severe. They just said they've got some diastolic dysfunction of some sort. Whether they had good contractility or not, good ejection fraction, didn't matter. There was a much worse survival compared to those who had adequate expansion or adequate relaxation of the ventricle. The green line here are people who had a low systolic function but normal diastolic function, so essentially isolated systolic dysfunction. A similar study here looking at patients who were mostly mechanically intubated found that a large number of patients had an abnormal E prime. Here they use the lateral E prime, which is a little bit higher velocity than the 8 centimeters per second. 10 is normal. But they found that that was also associated with mortality. Again, they found that E prime was associated with mortality, while these other markers were not. Now it's interesting, they didn't find that the E to E prime was associated, and some of that may be the challenge here of trying to associate this cardiac marker with the load component, the preload dependent component. When we take a large meta-analysis looking at diastolic dysfunction, which included those studies as well as some others, we see that diastolic dysfunction was associated with mortality, and E to E prime, the lower your E to E prime was, which means the more, the lower your E was, which is the worse your heart is doing, that's associated with worse outcomes. So people who had a vigorous relaxation did better, right? So we also see this with the E to E prime. When they looked at this and had bigger numbers, people who had a stiffer heart would have a higher E to E prime. People with a relaxed heart would have a lower E to E prime. And so we could see that in these cases that the patients were more likely to survive if they had a lower E to E prime. And so the way I think of this is diastolic function, is way more complicated than just a surrogate for preload, but it is, for the intensivist, our surrogate for preload. This is our replacement for the wedge pressure. And we found this, at least within our own population, in Utah, where we looked at a bunch of patients who were in septic shock, and this was early sepsis, like within the first 6 hours or so. And we found that the patients who were considered grade 1 were way more likely to have a higher mortality and receive less fluid. So this was how much fluid they'd received in the preceding 6 hours, and you can see that our cultural shift has been like these patients have received way less fluid after, in the past decade compared to in the 2000s. But patients here were thought to maybe have perhaps diseased hearts that were not adequately resuscitated. Now, this is a lot to extrapolate off of 11 patients, yet those were statistically significant. It was interesting that we found that most of the patients weren't actually graded within impaired relaxation, and part of that is the nature of the criteria for diastolic dysfunction by the American Society of Echo tends to actually miscalculate or misscore patients into either grade 0 or grade 2 or 3 when they're when we have sepsis. And part of that is due to the issues with the tricuspid regurgitation and the left atrial volume. So when we look at this, this seems to correlate fairly well with that prior study that I had shown, where we can see that when they looked at the mitral inflows, the E to A ratios, which are essentially people who have a very low E to A ratio, which would be impaired relaxation, had the worst survival. So this wasn't just found at our own institution. This was found in another large population, both suggesting that those patients seem to be most susceptible to mortality, perhaps related to low preload. We've operationalized this in a couple of studies showing that at least a simple version, instead of that giant complicated rubric that you saw from the American Society of Echo, seemed to at least categorize more critically ill patients and do a decent job of it. I'm not by any means recommending that this is the way to categorize patients, but it did seem to correlate well with clinical correlates of hypertension, diabetes, atherosclerotic heart disease, and at least it didn't miscategorize patients based on the possibility of having someone who's got a very elevated wedge pressure but still is somehow considered normal. And there's also, this has been used in a couple of other critical care groups, including a pediatric population by a different group, I think in Baylor. But so, one of the questions here is, well, we've got this wedge pressure. How good is that? It's this echo version of a wedge pressure. And as I imagine anyone who has familiarized themselves with the fluid and catheter treatment trial, as well as anything dealing with fluid responsiveness, would suggest that static measures are not really that good for predicting preload fluid response. The E to E prime can be used in a couple of other measurements, including appropriateness for weaning from a vent or identifying extravascular lung water. But as far as predicting fluid responsiveness, it's not great. So I'm going to show you this study right here looking at E to E prime. And this was kind of interesting because what they did was they looked after the fluid response, after the fluid challenge, whether or not the E to E prime changed. And you can see in patients who already had a stiff heart of some sort, if you gave them fluid, the patients who didn't respond to fluid ended up having a fairly big response in E to E prime, suggesting that if they're stiff and they're not going to respond, there is someone where you are basically going to give fluid and you're going to just get that left atrial pressure or left ventricular and diastolic pressure way up. And we presume that there's a harm with that in the sense that that would be associated with extravascular lung water. And so as of right now, there's not any data that really demonstrates that this is useful to predict fluid responsiveness. In practice, if I see a patient who's got a very high E to E prime, whether I make my decision for fluid responsiveness or not, I worry that that high value may suggest that that patient is more susceptible to the harms of fluid. And so I have given fluid in patients who have a high E to E prime, but I've also had patients where I've done, for example, a passive leg raise and it's been indeterminate, and I have a high E to E prime, and I say, well, maybe I'm going to wait till that passive leg raise is really high. Or if someone is do not intubate and I may have them on a high amount of oxygen, I may be more reluctant to give fluid based on that. Again, that's my own personal treatment. I'm not in any way advocating that because there's insufficient data to justify making any recommendation on that. So let's look at the RV now. So this is in every cardiology or echocardiography conference, they always talk about this as the forgotten ventricle, which makes me wonder if cardiologists are levocardiologists and maybe we're the dextrocardiologists, because this supplies, as I said, the most important organ of all, which is the lung. And I'm going to show you an example here. Now, because this supplies the lung, we're subject to a lot of problems when the lung isn't doing well. So here we have a patient who's got some pretty bad RV dysfunction. And if we didn't know anything about this patient, it might look like the RV is struggling. But it might be that this person might have a normal RV, or normal-ish RV, and they're experiencing the harms of excess afterload, PE, or ARDS. I'm going to show you a couple of ways we can assess the RV. Now, ejection fraction would be great, but the RV is not like this nice cone or bullet-shaped chamber like the LV. It's this odd kind of saddle-shaped or cape-shaped thing that's wrapped around the LV. And so what we end up doing is trying to take a two-dimensional measurement and saying, good enough. So one way we do this is fractional area change. And fractional area change is simply a two-dimensional EF. It's taking the end diastolic minus the end systolic and then dividing it by the end diastolic area. All right, and so you can see here, there's some examples of patients with varying fractional area changes. Normal should be about 35% or higher. Another classic measurement that we use is TAPSE, or tricuspid annulus systolic plane excursion, which is a mouthful, but basically it's just saying how much does that tricuspid annulus move up and down. And we can use M mode, which is a type of one-dimensional echo over time, and say, well, how much does that annulus move up and down? And we say, okay, this moved about 2.5 centimeters. Normal should be 1.7 or higher. Right? So those are two crude measurements that we can use. We can also use tissue Doppler, just like we talked about for the diastolic filling. We can look at that and say, well, how much systolic excursion is occurring? How quickly is the annulus moving up? While TAPSE was looking at how much it moved, S prime is looking at how quickly it moves. All right, so at least you have some idea of now of what these markers are that we're talking about. There's really two big studies, each having about 400 patients. And they had similar findings, although we use slightly different definitions. So in both populations, about half the patients with sepsis had RV dysfunction. So RV dysfunction was defined according to the American Society of Echo standards. And you can see this nice Venn diagram of either 3-component or 5-component looking at different issues here. So on the left, this was our study in Utah where we categorize patients into systolic or diastolic LV and RV systolic dysfunction. You can see about a third of the patients had isolated RV dysfunction, and about half had, RV dysfunction of some sort. Now, you can also see in the right side, this is the Mayo Clinic group, where they looked at all these different categories of RV dysfunction, fractional area change, the tissue Doppler S prime that we just talked about, TAPSE or RV enlargement. And then they said, well, the overall definition of RV dysfunction by whether or not a cardiologist called it that. And you can see that a large number of septic patients had dysfunction. One of the problems with this, though, is that the ventricle is probably, because it's so thin, is going to respond to fluid and swell up if you give a lot of fluid. And it's not going to do too well if you give it a lot of afterload, because it's so thin-walled, it'll balloon up if you have to make it do any sort of work. And so some of this may not be intrinsic dysfunction. It may be that what we're seeing here is actually a problem of afterload or preload. When we look at how these patients fared, we found in both studies that RV dysfunction seemed to fare worse than LV dysfunction. And so if you look here, this is the Mayo Clinic population, but you can see here isolated RV dysfunction on the right, right of this graph, the red line, had much worse survival compared to LV dysfunction or normal no RV dysfunction. So even having isolated dysfunction seemed worse than having both ventricles being dysfunctional, which is kind of odd. You would think that if both sides of the ventricle are performing poorly, that should be worse. But for some reason, it seemed that LV dysfunction was predictive. And one thing that we postulate on this is probably some component of this RV dysfunction is not really a measure of RV dysfunction. It's a measure of disease of the lung. And so that whenever you see RV dysfunction, you should be wondering, am I really seeing intrinsic myocardial dysfunction, or am I seeing ARDS? Am I seeing mechanical ventilation? Am I seeing excess fluid administration? And so even though the Mayo Clinic group adjusted for ventilators and PF ratios and vent settings, it's still possible that we miss some of that, and that some of this dysfunction is really a reflection of loading states rather that occur with severe disease. In our Utah study too, we had also found similar findings that the RV dysfunction was much more tightly associated with mortality than essentially any other parameter. And even though we accounted for receipt of ventilation and PF ratio and fluid and vasopressors, it's still possible that we aren't really capturing the full picture here. But this is remarkable, and it's gotten a lot of people very interested in what is going on with the RV. And so this is an area that's very ripe right now for future study. And so I want to emphasize, just to kind of illustrate what's happening when I talk about loading conditions here. You can see how thin the RV wall is compared to the LV. And what happens is if I give fluid, or if I give any extra work to that RV, it's going to end up ballooning up and contracting poorly. I'm sure from medical school, many of you guys remember and probably hate these pressure volume curves. But you can see in a normal RV, we've got this kind of relaxed ventricle. But as I get someone who gets excess work, whether that's due to a pulmonary embolism or mechanical ventilation, that RV starts to look more like an LV. It increases the volume both at end systole and end diastole, and it increases the pressure. And that ends up causing a lot of different problems. So even if the original problem wasn't myocardial dysfunction, that extra work ends up causing increased VO2 and decreased perfusion of the right ventricle. So even though it may have started off as just simply a mechanical excess bit of load, it ends up poisoning the heart in that regard. And just to kind of make this even clearer, I'm going to show you a picture. This is a patient who started off with they were septic, they were on a vent, and someone increased the PEEP. I think this was a Rose patient where we were trying to get them on board with the high PEEP protocol. Previous to this, Utah wasn't really. We said we did high PEEP, and when we looked at the numbers, we weren't actually doing that. But when we actually increased the PEEP, you can see the RV just balloons way up here. It's pretty poor visibility, but you can see on the left, it's a fairly normal looking RV, and now it's bigger than the LV. And we can also see the vena cava goes from collapsing to fully engorged. And that's all from just a little bit of excess ventilation. So why should we care about this? Well, I would say one is majority of patients in sepsis have some form of LV dysfunction. Probably about a third of them will have decreased ejection fraction right off the bat. And if you watch them over the first 3 days, probably about 2/3 will have LV dysfunction. And that's about the same number that will have decreased strain, or I'm sorry, increased strain within the first couple of hours. So strain appears to be more sensitive at identifying some of these patients. And a large number of those patients we think may develop lower ejection fractions later, or perhaps may have some future outcome, but that has yet to be determined. That's what I think a lot of people who are looking at this are pretty excited about. We can see about half these patients have RV dysfunction. And then the other key point here is with very little echo training, you can identify some of the most severe pathology, but about 5% of your septic patients will have some unanticipated critical finding, some severe valvulopathy or a PE or some other challenge where it's a profoundly low ejection fraction that you didn't anticipate. So all of these would justify, well, you should be imaging your patients. And again, this is where I would point out my intellectual bias here about how I think this is great, but my career is largely based on proselytizing how great this is. All right. I would also say, from a physiologic standpoint, as the ventricle worsens, our Frank Starling curve changes, and that should give us some information or be able to guide how we do volume expansion, right? So in theory, it should be able to allow us to recognize some patient where we might be able to tailor fluid or vasopressors. However, at least in a small pilot that we had done, we actually haven't been able to change anything. So even though we'd recognize myocardial dysfunction and say, okay, those patients, maybe they'll get more dobutamine or maybe they'll get epi, it hasn't actually resulted in any sort of meaningful clinical outcome. So in summary here, I would say that septic myocardial dysfunction is extremely common. It is associated with mortality, but a lot of those abnormalities might just be indicators of preload or afterload. And so it's really hard to say how much of this is intrinsic to the heart and that should be targeted as such, and how much is due to fluid, ventilators, and lung disease. But I would point out you don't need a full echo to use this information. You could basically learn the skills to identify some of the severity. Strain takes a bit of skill, but to identify severe ventricular dysfunction, you could learn that in an afternoon course. And I would say, even though you can learn all this and it's very exciting and there's a lot of interest in this, as of today, right now, there's not really any justification to say that identifying this or tailoring therapy based on this has actually led to improved outcomes.